Yeah, good afternoon, everybody. Thank you for attending our inaugural fall semester CPPI seminar. We have a very special guest with us today, our very own Dr. John Bucheit. He's an associate professor in the Department of Pharmacotherapy and Outcome Science. He specializes in ambulatory care or primary care pharmacy and practices under a collaborative practice agreement at Crossover Healthcare Ministry. He also serves as the residency program director for the ambulatory care residency at the VCU School of Pharmacy, and his areas of interest in research include cardiometabolic care, practice advancement, and interprofessional care. And today he's going to provide a firsthand account of billing Medicaid and his experience as an ambulatory care pharmacist. So without further ado, I will turn it over to Dr. Buhai. Thank you so much, and thank you for accepting our invitation.
Thank you so much, Dr. Salgado. It's really good to be here today talking to everyone about what I think is an important topic. And we'll go ahead and jump in. That was a great introduction, but really today we're going to be focusing on implementing the relatively recent new Medicaid regulations in an ambulatory care practice setting. And we really want to just provide some real world evidence that this can happen. We can do this as pharmacists. We have CE information, and Sydney will be putting this in the chat later, and I have no conflicts of interest to disclose. So initially, we're going to start off by briefly touching on the nationwide landscape of pharmacist billing here in the United States healthcare system and what the differences are state by state. We're going to discuss, zoom in a little bit more to see what's been happening in Virginia. And then we're going to talk a little bit. We have to cover a little bit of background information on a certain way of billing to really explain, illustrate a model that we have implemented at my practice site, which is Crossover Healthcare Ministry, and provide some real world data that we've had successful billing claims with these new regulations and codes. I do always put a disclaimer. This information is rapidly changing. And so please, if you're trying to implement new billing processes, no matter what state you are in, but also in Virginia, please make sure that you're looking at the most recent guidance because it is changing very, very fast. So we do want to start off nationwide and take a look at one of our biggest insurers in the US, which is Medicare. And these are for our patients typically 65 and older. And this represents one of the large insurers of patients in the US. Typically, other insured providers follow what Medicare does. And so we've come a long way from what's been happening with pharmacists' ability to bill Medicare Part B for services. Starting in 2014, and this was as I was a resident or shortly after I was a resident, a member from American Academy of Family Physicians made a very public letter to the chief officer at CMS asking whether pharmacists could bill Medicare Part B as auxiliary personnel. So pharmacists are not currently recognized as providers under Medicare Part B, which limits our ability to bill for services that we provide for patients who have Medicare. Later that year, Chief Tavener responded and said, "Yes, I agree with your rationale in this letter. I do think pharmacists as auxiliary, as the designation as auxiliary personnel, which is kind of a catch-all, but not really specific, could bill incident to services." So we're going to talk, they're going to hear incident to a lot in this presentation. We're going to walk through that later. But this was an important, very important time in pharmacy practice. And if you Google these things, you can see pharmacy organizations thanking these individuals for their help in this advocacy that really helped made the first step possible for pharmacists starting to bill Medicare Part B with incident to processes. In 2021, we made it into the final rule for pharmacists to bill auxiliary personnel, but there wasn't really any limitations on what pharmacists could bill. So could we bill an incident to process the same level of care as a provider in another profession? So those higher codes. So later that year, CMS clarified and said pharmacists as auxiliary personnel can only be limited to a level 1 code or 99211. Again, we're going to talk more about these different codes later. However, this is the lowest code, the lowest level of service that you could provide to a patient, and the lowest amount of payment for clinical services. Fast forward to present day, more and more opportunities are happening for pharmacists, including with Medicare. However, when you specifically look at evaluation and management codes, which in a fee-for-service model, which most of the United States is utilizing at this point, we are still limited to those level 1 99211 codes, even as of today. So, what about commercial insurance and Medicaid? So, pharmacy advocacy leaders have really had a lot of success going state by state and asking for changes within those states to get different support and coverage for pharmacy services that are paid for by commercial and Medicaid insured individuals. So 36 states now have some sort of legislation within their state that allows pharmacists to bill for their clinical services. 17 states have commercial insurance legislation, and 34 states have Medicaid. There's lots of differences within these laws. So this is one area where if you go state by state, there's obviously going to be some differences within what is covered. So some are very broad and some are very limited. And some states have both laws for commercial reimbursement and Medicaid payment. So really depends on the state you practice in, what you can do as far as getting payment for your clinical services from a commercial or Medicaid payer. However, this is a big step forward. So I think this is, in general, should be a sign of the success that 36 states have some type of legislation that allows us to bill for those higher level of services. Again, there are distinct distinctions. So there's scope of practice distinctions. Payment parity is a big term that may come up, which means if we offer a clinical service, if another provider offers that clinical service, do they get paid at a different rate, a higher rate than a pharmacist does? Some states restrict certain CPT codes, procedure codes that we can bill, and some restrict in practice settings. So while this is great, it's highly variable and it's challenging without national legislation to have one law that applies to all pharmacists, but it's been very effective from advocacy standpoint to go state by state. So we are going to have some multiple choice questions as we go here. So our first one is, which of the following insurance types have pharmacists experienced the most success with expanding billing opportunities? A, commercial, B, Medicaid, C, Medicare. Our pharmacists are equally limited with all insurance types. So if you want to put your answers in the chat box. All right, so I'm seeing a lot of answer choices for B, and I'd agree. So by far, Medicaid has been a big area where pharmacists in most states that have some kind of legislation have some type of coverage for Medicaid within those 36 states. So we've also, the second one I would say would be commercial insurance. And while Medicare, we have the ability to bill it is at a very low level. So it's highly variable depending on your state. And so we're going to talk a little bit more about Virginia. So as I mentioned earlier, there's distinction between scope of practice and provider status. Scope of practice defines the level of care that pharmacists are able to provide. This is developed by state legislatures and developed and regulated by their boards of pharmacy. Provider status, traditionally, we've thought about it as through Medicare Part B, and this recognizes pharmacists to get paid for their services. So provider status has nothing to do with scope of practice, it's to get paid for their services. So they are different, but they're really interlocked too. So if you don't have the scope of practice to be able to bill for certain levels of care, then you won't be able to optimize that pharmacist patient outcome. So you want pharmacists to have that scope of practice that allows them to practice at the top of their license and be able to get the provider status or the ability to receive payment from different insurers. Now, this all changed in Virginia in 2023. So this was really exciting. The governor signed a new bill 1538, which required Medicaid to cover services delivered by a collaborative practice agreement, also statewide protocols. It didn't specify how much or how to do that. But it did say that pharmacists need to be paid if they're offering these services under these types of practice models, scope of practice, thinking about either through statewide protocols or cloud of practice agreements, they need to be paid for this. So this is a really big step forward for pharmacists. If you want to know what the pharmacist scope of practice is in Virginia, there's the Pharmacy Practice Act that you can go to refer to. But this really designates what pharmacists are able to do in Virginia. And in Virginia, we have a pretty wide scope of practice that allows us to do a lot of different things. So when we talk about scope of practice, one of the models that we use is a collaborative practice agreement. And even this has been updated recently in the most recent legislative session, where pharmacists enter into an agreement with a doctor, physician's office, advanced practice provider. So this could be a physician assistant, nurse practitioner, and then a pharmacist. They work together and they enter into this collaboration together. And pharmacists, through this agreement, are able to prescribe, which is new language instead of initiate, prescribe, modify, or discontinue drug treatment. We're also able to order labs for drug therapy monitoring pursuant to a written protocol. So this allows pharmacists, if they're managing conditions that do not require a specific or that have a specific protocol or standard of care, then we can enter into collaborative practice with these providers. So very wide scope, very broad scope for pharmacists. It's not limiting us to specific conditions at all. It's saying if there's a standard of care, you can do it. Statewide protocols, these were a little bit more recent, and there are several in Virginia now. These are really nice because pharmacists do not need to have that relationship with a provider as long as they're following that statewide protocol developed between the Board of Pharmacy and the Board of Medicine, and they have a normal patient relationship with someone at their pharmacy. They were able to initiate these services. The one downside of these protocols is they're limited, and so if there's a condition outside of the statewide protocol, then pharmacists aren't able to manage it in the same way. And even within the protocols, there's pretty strict limits on what you can or cannot do as a pharmacist. So great step forward. Two different models. We don't typically use statewide protocols at crossover, but I do know that in the community setting, but also in the ambulatory care setting, others are using statewide protocols to um, augment their CPA as well. And just to provide a little bit of terminology, we have billing compliance, credentialing, and privileging. So these are really important terms. Each health system is going to have a billing compliance department probably, and their job is to make sure that you're billing appropriately and that you're not overbilling or underbilling, which would be fraudulent. Credentialing can be viewed as a couple different ways. Typically, this is granted within an organization or institution. So if at your practice site, you need to be credentialed. After that practice site verifies your credentials and your abilities and your education. And it's also important for third-party payers for the purpose of submitting paying claims. So for instance, in Virginia, if you want to bill Medicaid with a statewide protocol, you need to be credentialed with the DMAS, but also the MCO that services the Medicaid. Privileging is the process by which the organization you practice at allows you to do specific care interventions, and this is really based on each organization and their process for making sure that you have the correct training to do what you want to do. So just got to get through a little bit of definitions because a lot of this is really requires some baseline knowledge to go through. But this chart was adapted from a little bit of what we learned from DMAS at their initial education session. It really provided a lot of clear guidance on what to do with a statewide protocol. So if you're a pharmacist, you're providing services with a statewide protocol, you will bill under your own NPI number. So NPI number is a National Provider ID number. This is something that pharmacists can register for, and pharmacists would bill with their own NPI number. If there's no statewide protocol, and this includes collaborative practice, you would bill under the provider's NPI. However, there wasn't really any guidance on what this meant. What does this mean by provider's MPI? So we took this as meaning that under the provider is a process would be incident to billing. So this is how we looked at the guidance and how we implement a model that if you bill under incident two, then you'd be billing under the provider. I don't typically highlight resources in my presentation, but I do think because of this type of presentation, there are important resources to highlight. So DMAS, the Department of Medicaid Services in Virginia, provided a great educational session, so you can look at their materials there. They also have a frequently asked questions document. This is essential. So if you're talking to your compliance department, your billing department, your leadership, you'll definitely want to review the frequently asked questions document. There aren't really any big announcements that go out when this is updated, and I periodically check back. And so it seemed to be for a while that there weren't a lot of updates, but it was recently updated as of August 1st, 2025. So again, make sure you're periodically checking this for any changes and what they recommend for billing. But it's a great document to talk to your billing and compliance teams. And then if you want to see how much you'd get paid for a CPT code, they have a nice source for Medicaid with that as well. So as we move forward, I do want to highlight some information from the frequently asked questions document. And I think we've covered that if you're providing care under a collaborative practice agreement, do I bill under my own MPI? And the answer is no. You do not bill under your own PI. You would bill under the collaborating provider's MPI number. In the initial guidance that came out in their first frequently asked questions document that came out, DMIS specified that they do not restrict evaluation management codes 99202, 99211, 99213, and 99213 for pharmacists with a CPA if the billing MPI is at the collaborating provider and the service is within the scope of their CPA. So in that education session, they really talked about for statewide protocols, uh, the pharmacist is able to bill up to a level three or 99213 evaluation and management code. So DMAS provided in their original FAQ that they could bill for up to a level three, similar to a statewide protocol. About 6 months later, though, they updated this frequently asked questions, and this was probably one of the biggest, most crucial updates I've seen to this document. And it specified that DMAS does not restrict ENM codes for a pharmacist with a CPA if the billing MPI is at the collaborating provider, it is within their scope of their CPA. Pharmacists, if they're operating under their CPA, will bill for the evaluation management code appropriate for the patient encounter. So this is when we're talking about that pharmacists are not limited to certain CPT codes. You should bill based on the appropriateness of the encounter. So how do you determine that? Same way every other profession determines that. So make sure you're within your scope of practice, following your CPA, and following the American Medical Association for evaluation management definitions. The American Medical Association is the one that provides guidance on these types of codes. So this was a big step forward for me as a pharmacist when I saw this. This really meant big changes, and you'll see why as we talk about the amount of payment that you get with each of those things. So now's the point where we talk about incident to billing, and these are simply services that are supplied by a non-physician provider, and for us, it'd be a pharmacist, incident to a physician. And so these services are typical for a physician. This isn't something that's outside what the physician usually does, and they're involved in the care. It's also important that the initial visit is given to a physician, or in our case, it could be another advanced practice provider before they see the pharmacist. You cannot bill incident to until someone else has seen them and delegated that authority to the pharmacist. Services also require direct supervision. So there's different types of supervision, and you'll see this if you read the physician fee schedule. Direct supervision means there needs to be a physician on site that is readily available in case they are needed. This does not mean that the physician needs to see your patients before they can leave. So direct supervision just means they need to be on site and readily available. And this is important because if you're managing a chronic condition and something else is happening, that you may need to get evaluated by a physician or another advanced practice provider, they'd be available. So there's a checklist of things that you have to have for incident to billing. We've already talked about direct supervision. This is non-negotiable. I would also say things that I would like to highlight here. Eligible providers are and their auxiliary personnel, they must have a financial relationship. So you can't just work for one company and just go practice at other places and start billing. There has to be some kind of financial relationship. So typically you're an employee of that health system. However, for us, I'm a school pharmacy employee, but I have a contract with Crossover with our residency program that provides that financial care model. So you can be very creative with those financial relationships, but there needs to be some kind of financial relationships. And then, of course, the scope of practice needs to support the services that you're providing. For the providers, the referring provider is the one who makes the referral to the pharmacist. This does not have to be the supervising or billing provider. The rendering provider is the pharmacist who's providing the care. The supervising provider is the one credentialed by Medicaid who's on site. And the billing provider is also credentialed by Medicaid and is the one that's running the bills through. At Crossover, our supervising and billing provider are the same person, but the referring provider could be a number of staff employees at Crossover. So just some clarification on definitions. The referring provider does not have to be the supervising and billing provider, which allows flexibility because that allows you to be practicing in the clinic with different providers at different times. Okay, which of the following procedures should pharmacists follow to bill under the provider for Virginia Medicaid? A, Incident 2, billing guidance. B, Medicare administrator contractor information, statewide protocol, regulations, or Virginia Scope of Practice Act. So, based on what we just talked about, what would be one of the effective ways to um, bill under the provider based on Virginia Medicaid guidance? If you want to put your answers in the chat. You got it. So A, incident two billing. Yeah. So when choosing the right evaluation and management code, so these are the codes. Evaluation and management codes are simply codes that providers use to evaluate or manage patients. That's pretty much the definition of those codes. So there are two ways to choose the right ones. You can either choose them through medical decision making. And so you need to have two out of three criteria met: risk, number, and complexity of problems addressed, and or data review and analysis. So there's three components to that medical decision making area or time. And so time's probably the most straightforward one. And if you see a patient for a certain amount of time, you're able to bill for that service. So we are going to walk through these a little bit and what the codes are. So remember for time-based coding in Virginia, that would be 99202, which is a new patient visit, a 99211, a 99212, a 99213, and then a 99214 and 99215 are on the next screen. However, with collaborative practice, you would never use a 99202 because one, for collaborative practice, that would be something that the physician or advanced pharmacy practice provider would initiate instead of referral to. And actually, same goes in line with incident two. So remember, for incident two billing, you're offering that service on behalf incident two, a physician or advanced provider, and they need to see the advanced practice provider or physician first. So we're going to focus on the other five codes. The time limits are listed here. So if you're less than 10 minutes, you're looking at a 99211 or a level one code. 10 to 19 minutes is a level two code or 99212. And 20 to 29 minutes is a 99213. So I would say for my practice at Crossover, when I see patients with complex cardiometabolic diseases, I'm probably based on time alone, probably in the 99213, 99214, 99215 area. So 99214 would be a 30 to 39-minute visit, and the 99215 would be 40 to 49, or really more than 40 minutes. Now, it is important what counts when you're documenting time. So time counts on the same day as the visit, preparing, reviewing notes for the patient, interviewing the patient, documenting any other patient care duties that you do on the day of the visit. So even if you see the patient for 25 minutes, if you're doing other things for more than 5 minutes, you're automatically hitting that next level of coding, that 99214 for 30 minutes because you were reviewing notes, documenting, and doing other care measures. So keep in mind that this is not just about the time you spend with the patient. It is all those on the same day, all those different patient services that you provide. And just keep in mind that for statewide protocols, DMS has determined that we cannot bill beyond a 99213. So this is really important. So if you're doing time-based coding, you really need to keep track of your time as you're seeing patients. So we could probably spend 50 minutes on coding using medical decision making. So bear with me on this. It is a big topic, but I do want to highlight a few things. So remember, you have to meet two out of the three categories to be able to bill at this level. So these categories are number and complexity of problems addressed, amount and/or complexity of data review and analysis, and the risk. And it doesn't really get to level four where they provide examples of risk, but this is what you're looking for. If you have um, two out of the three in a certain area, so if you have two boxes in level three, but one box checked for level two, you would bill at a level three visit because you would meet two out of the three criteria. So remember 99213, which is what we originally recommended to be billing for. What they look at as far as from the American Medical Association, number and complexity of problems addressed is one stable chronic condition. And with my collaborative practice, and I think with most collaborative practice, we're managing chronic conditions. And we don't typically get patients with stable chronic disease referred to us, right? So as pharmacists, they're asking for help with complex med management for people with complex conditions. Um, the amount and/or complexity of data review, this is a lot here, but you need to be able to meet either category one or category two, and they don't really provide a definition for low risk. So it's a little tricky with the low risk, but in general, 99213, if you look at the patients that we typically see in clinic as ambulatory care pharmacists, we're not seeing patients with stable chronic conditions. Maybe sometimes if we've worked with them and they're meeting their treatment goals, but the majority of the patients are going to have one or more chronic illnesses with an exacerbation or progression or side effects. This really, another way to say this is a patient with an uncontrolled chronic illness. Okay, so if they have one uncontrolled chronic illness, we're already looking at number and complexity of problems addressed in the moderate category, and we're already starting out at 99214. So that ability for that document, and it says that pharmacists should bill based on the appropriateness of service, we should be really living here for those patients with uncontrolled chronic conditions in this level, at least this level four category. The amount and complexity of data review gets more complex, for lack of better words. So you have more categories that you have to reach to get there. But in the level of risk, it provides some very specific examples. So prescription drug management. So if you're evaluating or assessing, making changes, stopping, starting, increasing doses, you're automatically from seeing at least one uncontrolled chronic illness and prescription drug management, you're living in a level four billing area. And that's really what we should be billing for because that is what's appropriate to bill for evaluation and management codes. Level five codes, these are for very sick patients. So these are for patients that we think that may need to go to the hospital or having severe exacerbations of illness. I don't typically bill 99215 at my practice site unless I hit it with the time threshold. And so, as we talk about with patients at my clinic, many of them do not speak English. They've are coming from different countries, new to the United States, trying to navigate a complex healthcare system. So there's lots of challenges working with patients. So sometimes I meet that threshold more based on time than complexity or medical decision making. We also bill at Crossover for continuous glucose monitoring. So continuous glucose monitoring is for patients with diabetes. And they have these devices that you can put on your arm that last 10 to 14 to 15 days. And they measure glucose 24 hours a day. And you get a nice ambulatory glucose profile report. There are several codes you can use, and the ones that are most common are the 95249. This is when a patient is starting on a new device. You physically help them put that device on in clinic, you educate them, and you can do this once per new device. So even if it falls off and you need to help them again or train them again, you can only bill this one time. You also can't bill it on the day that you offer it. They have to come back with 70, at least 72 hours worth of data. So that's a little challenging sometimes that patients come back with the data. You have to wait for them to come back with the data before you can bill for that. The 95250, that's professional CGM. These are typically blinded to the patients. Offices will buy the CGMs, continuous glucose monitors, and have certain technology in the office to record the information when they come back. We don't use these at crossover, but this is another method that you can use. I would say is probably less frequently with the newer development and the personalized CGMs that we have available. 95251, this is really your ongoing chronic management. So you're allowed to interpret and manage 95251 with continuous glucose monitors. You can only do this once every 30 days, and you do need at least 72 hours of data. But this is a really nice thing. If you're managing patients with diabetes, this is a modifier for those patients, and you're allowed to add this on top of your evaluation and management code. All right. So if you go to that resource that I provided you about payments for services by Medicaid, you can get an estimate on what you will receive. And so $17 for a level one visit, all the way up to between $100 and $130 for a level five visit. And so I think if you can do the math in your head real quick, being able to bill at specific levels that are appropriate for your care really does affect the financial viability of having a pharmacist in an outpatient setting. I did look for the continuous glucose monitoring codes. I was not able to get information for those, so I don't have anything to share for you on that, unfortunately. Um, so that was just a brief overview of Incident 2 billing. And so it's a little complex. However, I say it helps a lot to have already had a collaborative practice agreement set up at my clinic. And the procedures for making it into an Incident 2 process was really minor and really easy to do. So we're going to talk a little bit more about that. As we talk about crossover healthcare ministry, this is a really neat clinic. It actually has two practice sites in Virginia, and it's a physician-based clinic with over 7,000 patients. Most patients that are served at crossover are non-English speaking. We do have English speaking patients, but the majority are non-English speaking patients. And they estimate that patients come from over 118 countries worldwide and speak over 40 different languages. So Crossover is also a charitable health clinic. And so the differences between a charitable health clinic and a free health clinic is that Crossover helps patients who are uninsured and patients with Medicaid. With that being said, I would say approximately 20 to 25% of patients have Medicaid at crossover. So still the majority of our patients are uninsured at crossover, but most of our patients have Medicaid. I'm sorry, most of our patients are uninsured, but we do have a good about a quarter size of patients who have Medicaid as well. Now, we also, speaking as a pharmacist, we only see a portion of that quarter of patients with Medicaid. So still most of the patients I'm seeing are uninsured. Pharmacists that services at Crossover, we are, as I mentioned, we're delivering on our collaborative practice agreement. It was already a process and procedure before I was at Crossover over 15 years ago. Now our focus is cardiometabolic disease, so diabetes, hypertension, dyslipidemia, CKD, weight loss. However, we are true primary care pharmacists. We get referrals for a lot of different disease states to help manage from our providers. So this is kind of laying the landscape for crossover. On the right here, we have our model. So when a new patient comes in, their eligibility is reviewed. They go see a physician or advanced pharmacy practice provider, like a nurse practitioner. And then those providers decide whether it's appropriate to see a pharmacist. We don't have specific criteria. Traditionally, at least an A1C greater than 9% has been the case for patients with diabetes, but we do see a wide range of complex cardiometabolic diseases. So they could be referred for multiple reasons. Pharmacists practice on a collaborative practice. We do comprehensive medication management. So not only do we see them one time, when we see them, we're evaluating, we're assessing, we're following up, we're monitoring as appropriate. We're also making referrals for dental, ophthalmology, behavioral health as needed. And if their goals of care are not met, then they will see us back probably sooner rather than later. So we try to see patients as quickly as we can to help them get to their goals as quickly as possible. So this is the advantage about collaborative practice. You get more touches in the healthcare system by adding that pharmacist. However, they do still see that PCP at least annually, if not more frequently. Once the patient's meeting all their treatment goals and we've sustained their treatment, we do graduate them and let them be followed by their primary care provider, but they're always welcome back if we need to. Some highlights of our clinic. So we incorporate learners in our clinic. It is a teaching clinic. So most days I have at least two students in my clinic, if not more. I also typically have a PGY2 resident in my clinic. Not every day, but most days. As I mentioned, the focus is on cardiometabolic care. And throughout this process, as we really utilize incident to billing as needed and collaborative practice. So as my time has changed over, as I've been there for 9 years, lots of things have changed. So I established my practice in 2016 at Crossover, and in 2019, Virginia expanded Medicaid. So this was a big deal. So Crossover went through a transformation in 2019 and started accepting Medicaid shortly after they were able to. While the processes were established for other staff providers at Crossover, I quickly began to talk to the team about what about pharmacists? We should be able to bill for some of our services too, because I think it's important for pharmacists when they can get paid for their services, we should get paid for our services. In 2023, the new Medicaid regulations were signed into law. And then in 2024, and I will say this was really impressive, DMAS released their FAQ document, their frequently asked questions document, very quickly. So some states it's taken years to implement policies and procedures. Virginia Medicaid did that really fast. And as soon as that was released, we were ready to go because it didn't require a lot of changes at Crossover for pharmacists to start billing. So who did we have on our team? So our dream team at Crossover, it is a smaller organization than a big healthcare system, but we had a billing department leader who's very open to hearing about pharmacist billing and how we could do that. We have a physician champion. Our medical director, Dr. Murchie, was worked with us all 9 years since I've been there. I was obviously pushing very strongly for practice for being able to bill, just because I think it's important for pharmacists to do that. We already had the capability and a data analyst to collect data and look at various aspects of care. So we've focused mostly on quality of care in the past, but we did have someone ready to go to monitor to see how pharmacists were doing as far as success in billing. And then our CEO has been very supportive as well. Again, we have this relationship for since I've been there and before me for over 9 years that this resident and faculty member coming over to Crossover to see patients. All right. So when talking about Crossover Healthcare Ministry, which of the following best describes the scope of practice utilized by pharmacists there? Collaborative practice, group visits with providers, self-prescribing privileges for pharmacists, or statewide protocols. You put in the chat. Yeah, so I think we got this one. We use collaborative practice, right? So I really my intention for that question is really just to continue to highlight how if you're already doing collaborative practice, implementing billing is really not that hard to do as from a process standpoint. So you have a lot of key processes that you can build upon. So at Crossover, our foundation, the things that we have, our strength, we had eClinical Works, we had an electronic health record. We have a data analyst, which uses Bridge IT, who can collect lots of data. We've had an established collaborative practice model and a leadership team that valued pharmacist-led care. The other thing that was important, that was helpful at the time, is that all the providers who used to only see uninsured patients are now seeing patients with Medicaid, and we're billing for patients with Medicaid. One thing that we did not have that Crossover wisely invested in was a billing and operations employee. And this person was instrumental to helping us as pharmacists get paid for our services as well. Once we had the billing and operations employee set, we faced very little barriers to implementing that pharmacist billing under the provider incident 2. Again, in 2019, though, I must say, or really in 2020, when pharmacists began billing, we were following the Medicare Part B guidance that pharmacists could bill at a level one code, and we were able to bill CGM codes only. So we were starting off very low, but we were billing 99211s and CGM codes right from the beginning that we were able to. So at crossover, who's responsible for a lot of these things? So the scope of practice. So when I get a referral from a physician or advanced practice provider, I'm ensuring that the referral is within the scope of practice. I'm concerning what's in our collaborative practice agreement and that we're following incident to regulations. The documentation, this is really probably mostly on the pharmacist as well as we're seeing the patients. We need to make sure that our documentation justifies for the billing codes that we're using. The pharmacist, again, is going to determine that ICD-10 code and the evaluation management code build for that visit. And the billing provider is going to review the note and sign off on it. And it's going to be billed under their MPI. So what are some things that we put in our visits to help with billing? Typically, some of the providers requested that if we're doing incident to billing, to make sure that there was some information at the top of the note that this was an encounter that was performed without the referring provider present, because it was a little difficult to tell based on how the notes were adjudicated. We also put the referral date on who is referred by and the referral date on each note. So make sure that we have a staff provider and that I try to keep that date updated within at least a year. If it's not, I request for a new referral or updated referral to be placed. I also put at the beginning of my note that this patient, after I go through their past medical history, that this patient was referred to the pharmacist for, and why are we seeing this patient today? So if we have a referral in the system, we need to make sure we're documenting in our clinical note what that referral was for to make it very easy in case these things are reviewed or audited. We also document our time for each encounter. So time spent included documentation, interviewing the patient, and other patient care responsibilities, but we do put total time spent with patient. We also indicate if it's an office or telehealth visit to make sure that patients are that when submitting this note or this claim, that it's easily distinguishable between a telehealth visit and office visit. We will select the ICD-10 code, and this isn't hard to do if you're doing this in clinic all the time. This is something that's pretty straightforward. If you're not doing it, ICD-10 code is usually, again, should already be in the system if the provider is referring this patient to you. So you simply bring it over from the problem list or their history. Otherwise, you search for the ICD-10 code. So, for instance, you can type in type 2 diabetes and find the right ICD-10 code that matches the referral. And then the last thing is to make sure that if you're going to bill for this encounter, I always make sure if I was referred for this patient's diabetes, then I'm billing under this patient's ICD-10 code for diabetes. When it comes to adding CGM codes on top of that, you can bill for a 95249 or 95251. This requires a modifier to be put in the electronic health record under the evaluation and management code. We've already talked about how you need 72 hours worth of data, and you need to provide the ambulatory glucose profile and that data from that profile and interpretation of that data into the chart. And then you can only bill this no more than 30 days. So let's walk through one example here and make sure that hopefully that we're on the same page with everything. So we have Camilla as a 42-year-old referred to the Pharm.D clinic for diabetes management. She has a past medical history for obesity and type 2 diabetes. She's currently taking insulin glargine 34 units daily and metformin 1,000 twice daily. You can also see some vital signs here at the bottom left. Her labs today, her A1C is 7.8%. Her GFR is greater than 60. For her assessment and plan, the pharmacist has decided the patient is not at goal. Her A1C is not less than 7%, and her time in range. So if this patient had a continuous glucose monitor, like a continuous glucose monitor, it would be less than 70%. Also, we need to interpret that the ambulatory glucose profile. So the AGP would indicate that there's post-meal spikes in the blood glucose, suggesting that her fasting blood glucose sugars are okay, but after she eats meals, her blood glucose values are going up. So would recommend, based on this, that we start dulaglutide, which is a once weekly GLP-1 receptor agonist, to help with her current treatment to help optimize her diabetes care. And this would also help with her chronic condition with obesity, trying to help lose some weight as well. So when we talk about billing, the reason we were seeing this patient was for uh, type 2 diabetes. We would put in our note that the provider was not present for this visit. The reason for the referral, the patient was referred for diabetes management. We would also indicate that it was an office visit. So making sure that the Medicaid auditing does not get confused between a telehealth visit and an office visit. I also documented time and what I did with this time. So I saw this patient for 27 minutes. And in this time, I was reviewing notes, interviewing the patient, documenting, and care coordination. I also selected type 2 diabetes for the diagnosis code. And since the patient had an ambulatory blood glucose profile and a CGM, I added a 25 modifier to the evaluation and management code and billed for a 95251 on top of that. Then I would assign the note to the supervising provider. So as we go through these through this case, we in this next question, which of the following evaluation and management codes is most appropriate? So A is level 1, and it goes up to 2, 3, and 4 to D. I'll go back to the case so you can figure out if you want to do 99211, 99212, 99213, 99214. So how would you bill for this patient based on either medical decision making or time? And again, whichever one is your highest, you should go with the highest. So if time and medical decision making do not go together, you should go with the one that offers the highest amount of payment or highest amount of appropriateness of service. So go ahead and put in the chat which code you think is most appropriate. 99211, 99212, 99213, or 99214. Okay. All right. All right. So this patient again has Medicaid, and this patient was seen for 27 minutes. So I'm seeing a couple of different answers. So if this patient had Medicare, I think the best answer would be a level 1 visit. A 99211 code would be all you could do. If the patient has Medicaid, then you have to start determining whether this patient meets criteria based on the time spent with the patient or the medical decision making for the patient. So I think this is where we get confusion over a level 3 visit, 99213, and a level 4 visit, 99214. So on a level 3 visit would be appropriate for 20 to 29 minutes would be a level 3 visit. That's correct. But remember, for medical decision making, if you have one uncontrolled chronic condition and you have you do some prescription drug management, then you're automatically meeting criteria for a level 4 visit. So actually, the best answer for this would be a 99214 for this patient. And so, do want to give some real world evidence to say that we can do this proof of concept for pharmacists in Virginia. And this is relatively new. And these things take time. Clinical practice guidelines take time to implement. And also, yeah. So before I get into this, yeah. So the policy is you default to what's most appropriate. So if you're through your medical decision making, you want to make sure that if that's a higher level code, you've reached that level of service, you should bill based on the level of service. You don't bill based on the lowest level of service. That the best practice is to bill based on what's the highest level of service that you meet based on either medical decision making or time. Okay. So I see the question there about scheduling patients in ECW. I will definitely talk about that. I do want to make sure I get through the real world evidence, but I think we'll have time to answer that question. So if I forget that, maybe Dr. Salgado can remind me to answer that question here at the end. Um, and so we retrospectively reviewed patient data at Crossover of successful claims billed in three different time periods. So July 2023 through December 2023. And this was actually before the new regulations went into effect. We also looked at the 6 months after the regulations went into effect in Virginia and with the most recent guidance. And so remember at that time we were billing at a level 3 was the optimal code that we were billing. And then in July 2024 to December 2024, we were billing at the highest, or I'm sorry, we were billing based on the newest guidance, which is the bill based on the appropriateness of the patient encountered based on the American Medical Association's criteria. So we just wanted to see how much of our claims were being successfully processed based on each evaluation and management code. So we talked about this in July. In 2023, we were limited to 99211 codes and 95249 and 95251 continuous glucose monitoring codes. And in January to June 2024, we're able to bill up to 99213 for evaluation management codes and continued with continuous glucose monitoring codes. And then in July to December 2024, we were able to bill up to 99215 and continuing with the CGM codes as well. So here's a breakdown of the different codes that we used. Again, you're seeing that almost all the codes um, used for patients in um, 2023 were 99211 codes. And then as we move through, we're seeing in the second time frame from January to June 2024, we're starting to get more of those 99213 codes. Most of our patients are meeting those codes. And then lastly, in July 2024 to December 2024, the majority of our codes were 99214. We also had three 99215 codes as well. So if you look at the revenue generated, again, keep in mind that crossover only has about 25% or 20 to 25% of patients with Medicaid, and I only see a portion of those patients in my clinic. Most of our patients are still uninsured. So this really takes into account just for patients with Medicaid. And what you can see is it's really hard for a pharmacist to get much payment for their clinical services prior to these new regulations with Medicaid. So with Medicaid in 2023, it's getting those low payment rates is really challenging if you wanted to hire a pharmacist, it'd be really challenging to cover that salary and those benefits for the pharmacist. In 2024, the revenue jumped up to nearly $7,000. We also had more encounters at that time, 132 encounters. And then in July to December 2024, the revenue actually, we saw about 50 fewer patients at that time, but the revenue was just a little bit lower. So on average, we were getting a lot higher payment per bill submitted for patients. Keep in mind that I did not change my process of care. I was seeing patients with uncontrolled chronic conditions and billing based on the appropriateness of the care that I was provided. I think when you see the differences in encounters, which makes the numbers look a little bit different based on this chart, keep in mind that in July is usually when new trainees start, including residents, so they're getting acclimated to the service as we're helping getting them started. So we typically see fewer patients in the summer months, which I would say would probably be consistent if we continue to look forward with this data. So by seeing 50 less patients, there really wasn't that much difference in the reimbursement rate. We still were very close on getting payment. But if you go back and look, most of our payments were for 99214 at that time. So uh, my take-home points, pharmacists, uh, the new Medicaid regulations allow pharmacists to bill based on the appropriate level of service. So you can do it. You can get paid for it. It has been done, and there's proof of concept here at Crossover. And this is real world data. And pharmacists, I think, should be doing this to make sure that not only are we getting paid appropriately for our services, if we want to continue to offer more pharmacy-based services in the outpatient setting, really need to be able to justify having a pharmacist there. And you can do this in a lot of different ways, but having this financial ability in this current fee-for-service market for most places, it really allows the pharmacist to get paid at that higher rate as long as you're seeing Medicaid insured individuals. So with that, I will be happy to take additional questions. There are resources here at the end as well. And so these are really good documents. Definitely take a check those out if you have not seen them. And I think I will start with that one question. I definitely didn't want to leave Caroline hanging out there. Um, so in ECW, so how do these patients get scheduled? So and crossover, what we did with our system is when we put a referral in.